Thank you, Kate. So it's great to see everybody, even if just in virtual format today. Still getting used to the surreal opportunity to present on a cell phone or a computer. So I am currently working as a full-time hospitalist at ChristianaCare. I split my duties between teaching medical residents and medical students and taking care of sick people on the medical floors. And I spent most of my weekend in the rooms of people who have influenza A and COVID. So our discussions this morning are certainly relevant to my work. I have no interesting disclosures. Next slide, please. And next slide, please. So our objectives for today, really objective for today, is to go through the significant changes that have occurred in the ACIP's recommendations for adult immunization just over the past few years. And especially over this year, a couple of interesting developments in our schedule. We'll also look at a couple of tools that are available to us from the CDC to help us remember all of this. And I'm not going to touch on COVID-19 or Mpox. They've been well covered by Rick Hong and other speakers before me. Next slide, please. So I always like to get warmed up for an immunization talk just by looking back on some of the activities of our forefathers in immunization. And Dr. Riley touched on this a bit with the efforts of Edward Jenner with regard to developing perhaps a first vaccination procedure called variolation, in which he injected exudate from cowpox lesions into another person, a willing volunteer, providing protection against infection with smallpox. In 1885, Louis Pasteur, who's known for another process, developed the first rabies vaccine, material from an infected rabbit brain subjected to a drying process and then administered to a patient. And this was effective. In 1897, we had the development of animal sera against tetanus toxin. And although there were significant adverse reactions to the animal sera, and 10 to 15% of patients who received that, it substantially reduced the incidence of tetanus during the First World War. And then by 1921, we had antitoxin versus toxoid to tetanus. DPT vaccine came along in 1931. And next slide, please. And then, of course, we all remember the polio epidemic of the 1950s in the United States, in which there were close to 60,000 cases and 3,000 deaths in 1952. Dr. Jonas Salk developed the inactivated poliovirus injection. By 1957, there were less than 6,000 cases in the United States. Speaking to the effectiveness of that, that particular vaccine did have a small incidence of vaccine-associated paralytic polio, and Dr. Sabin continued that work in 1962, introduced the oral polio vaccine, safer and more effective. Of course, measles in the 1960s was a significant problem in the US. 3 to 4 million cases, 48,000 hospitalizations, 1,000 cases of encephalitis, and about 500 deaths per year there for a while. Dr. Enders developed the first vaccine in 1963, and by 1968 we had the Edmundston Enders strain, which to this day is still used in our measles vaccine, although we have a new measles vaccine product on the market this year. And by 1998 in this country, we had only 89 reported cases in the US of measles. And nowadays we do see measles in the US. In fact, there have been some recent reported cases in Pennsylvania. But most of the measles cases are imported or in areas where people are under immunized. And of course, as we heard earlier, in the late 70s, smallpox was reported eradicated from the world as a result of vaccines. So That's just absolutely amazing. If we look back to the major medical developments of the 20th century, we can think of five that kind of make the Hall of Fame. And of course, modern surgical and anesthetic techniques and cardiovascular disease and cancer, but also antibiotics and immunizations have had the biggest impact on morbidity and mortality of the human race. So when I first went into practice as an internist back in 1990, which is also historic since it was in the last millennium, I thought, oh, adult medicine, that's going to be a piece of cake in the immunization department. We'll just give a tetanus shot every 10 years and a pneumococcal vaccine at age 65, a flu shot every fall, and we're in good shape. And of course, it's not that simple, and it's become a good bit more complex. Some people develop diaphoresis when they see this slide, which is the current CDC schedule for adult immunization. And it's published by our CDC every February or so, and it's available on the CDC website. It's also published in the Annals of Internal Medicine. So those of us who are internists, it's nice to see that come out each year around about March 1st or so. And although this is onerous, it is quite useful. And I download these slides every year and stick them on my desktop and remind myself of what I should be doing. Even in the inpatient setting, we do give some immunizations. But you can see here that the various vaccines are on the y-axis. And going across the top here is age indications for the vaccines. If we go to the next slide, we can see that we have the vaccines on the y-axis again, and now we have medical conditions going across the top on the x-axis. So a different way of looking at indications for patients, and this guide has gotten better and easier to use, although it is rather complex. On the next slide, you can see some instructions from the CDC about how to use these schedules. And it's nice to have these 3 slides just downloaded to your desktop or your phone every year for reference, because it is somewhat complex. So we'll go on to the next slide. So why are we talking about adult immunization in 2022? Wouldn't it just be great if everybody got the vaccines that they needed, and we wouldn't really need to talk about it because the job would be done? But of course, there's this. This is data from CDC from 2010 to 2020, indicating that we're not doing such a great job in the adult population. Our pediatric colleagues have admirably immunized more than 90% of their patients when they can do it. That varies with the demographic and with access to healthcare, but in the adult population, we're way behind. We can see that uptake of certain vaccines in the general population, such as pneumococcal vaccine or even tetanus vaccine, may be as low as 15% for the targeted populations. And even in our highest risk populations, like 65 and up, we're only seeing about 2/3 uptake of influenza vaccine and pneumococcal vaccines in the upper curves there. So we have a lot of work to do to catch up in achieving the kinds of impacts that immunization made back in the 20th century. And embarrassingly and somewhat alarmingly, there are significant racial and ethnic disparities in who gets vaccines in our country. And these curves are comparable for every single vaccine that we recommend for our adult patients, not just influenza. This is the influenza data here. You can see that even in 2020, perhaps only half of the Caucasian population, this is all ages of adults, received influenza vaccine. And if you look at the data for folks that are 65 and up, about 72% of Caucasians got influenza vaccine, and then it drops dramatically to the low 50s for African American persons, and for Hispanic persons, it's even down in the 40% range. So very embarrassing, and clearly this is something that we need to work on in our country. Next slide, please. So let's talk about influenza, since we're in the midst of an influenza outbreak right now. And as I remember from my weekend activities on service, we are are not immunizing everyone. And of course, our vaccines are not 100% effective in preventing disease, but every little bit helps. So the recommendation for influenza vaccine is easy. Let's give it to all of our patients that are 6 months and older who have no contraindication, and the contraindications are few. If someone's had an allergic reaction to influenza vaccine, we have a way of dealing with that, depending on its severity. And previous Guillain-Barré syndrome, even though we haven't seen a direct relationship of influenza vaccination to Guillain-Barré syndrome since a certain lot of influenza vaccine back in 1976. We're still careful about it. And if somebody develops Guillain-Barré within 6 weeks of receiving influenza vaccine, then we generally recommend against it. So the vaccine is given throughout the flu season, which is usually between September 1 and the end of March. Last year, we were seeing flu cases in April and maybe even in early May. So it's certainly reasonable to give the vaccine to our patients right throughout the entire flu season. So if you see somebody in the office in February and they haven't had their flu shot yet and they haven't had influenza, it's certainly reasonable to recommend that they get it, even though it's relatively late in the flu season. There are good or best times to get influenza vaccine. We think it's optimal to give influenza vaccine to older adults and adults in general between September 1st and October 31st. But of course, we can give it any time through the season. It is available in July and August, and a lot of times we'll see the pharmacies pushing it. We think that it's okay to give influenza vaccine to pregnant women in the third trimester of pregnancy in July or August, and also children. But for our adult patients, especially our older adult patients, we want their antibodies and their T-cell effects to be around in the fall when they're going to first encounter influenza virus. And this year we had a bit of an early outbreak in early November. So best time to get the shot is a few weeks before you encounter the virus. And therefore the September-October thing is a push for us. We do see pandemics from influenza. The last one memorable was 2009, a novel H1N1 virus that was bringing patients to my office in May and June with influenza, moderate severity, and certainly the 1918 Spanish influenza pandemic with millions, tens of millions of deaths worldwide, and perhaps 3 million deaths in the United States, very memorable. And then we've had smaller pandemics in 1957, 68, 77, and then the most recent in 2009. So we get reminders about how severe influenza can be. The number of cases per year varies dramatically depending on which virus is circulating and the virulence of that particular virus. We do see antigenic shift, and therefore the reason for us to re-up the influenza vaccine for our patients every year. The impact of influenza annually, hospitalizations 140,000 to 810,000 per year. Deaths are estimated at 12,000 to 61,000 in the US. And on average, about 133 children die per year. We recall the particularly bad 2017 to 2018 influenza season in which we had nearly 80,000 deaths attributed to influenza. And generally, the H3N2 viruses tend to be more virulent and a little less responsive to the effects, the protective effects of the vaccine. And the predominant virus in this year's outbreak is H3N2, whereas we're seeing more H1N1 last year early in the season. Influenza B viruses tend to come later in the season, in the wintertime and in the early spring. And I haven't seen any cases of that this year, but of course it's around. Next slide, please. And here's a shot that's similar to what Rick showed earlier, hospitalization trends from influenza-like illness showing an early onset of the flu outbreak this year in early November. You'll note that the blue curve down at the bottom was 2020 when everybody was staying home and wearing masks with our COVID pandemic. And well, flu is back in action. The next slide, please. This one shows, I'm sorry, made an error on my end. There we go. This is the number of people who are vaccinated in Delaware by age group for influenza based on data from a couple of weeks ago. And you can see that just like our national data for immunization, that we're under immunized in Delaware as well by percentages. So our 65-year-olds made it to 60%. Clearly, we need to do better. Next slide. And as we heard earlier, we are seeing some cases of RSV. They spiked up in early November in week 43. Week 47 was at the end of November. And as influenza is taking off, we're seeing a little bit of a downtrend in cases of RSV, but it still remains a very significant concern. Our respiratory floors at ChristianaCare frequently see patients with RSV, particularly if they have underlying lung disease such as COPD or other types of lung diseases. And frequently we have them on our respiratory floor, 3D step down, in trouble, significantly hypoxic, and sometimes in the ICUs on ventilators. Next slide, please. So a site that I like to use for immunization information in general is the IAC site. I think they're kind of branding themselves now and just calling themselves immunize.org, which is a convenient way of remembering how to get to their website. But they have a ton of really useful information on the IAC, used to stand for Immunization Action Coalition. And I love going to this site every fall and seeing an update on the different vaccine products for influenza. And I usually download this chart here. And this has gotten simpler over the years. There's less products on there now, but it shows us all of the different immunization products available for influenza. So a lot of data on that slide. I won't review it with you, but it's an interesting thing to look at if you're curious. Next slide, please. So here's what's in our quadrivalent inactivated influenza vaccine for this season. 2A viruses, 2B viruses, and 2 of the strains, 1A and 1B, are new compared to last year. We hope to get some more mileage out of our H3N2 virus that's in the vaccine this year, especially since that's what we're seeing in the community. And there's a new influenza B in there as well. So there's no more trivalent vaccines on the market. They've been replaced by the quadrivalent vaccines, which give additional protection. These are the viruses that are in the egg-based vaccines. They're a little different for the recombinant and cell culture vaccines. Next slide, please. These are the viruses that are in the cell culture and recombinant vaccines, a little different than the ones in the egg culture derived, still offering protection against the important influenza A's. Next slide, please. So what are our recommendations for patients over the age of 65? This year, a new recommendation from ACIP is an endorsement of the 3 vaccines listed on this slide: the high-dose inactivated influenza vaccine, which has 4 times the hemagglutinin antigen in it compared to standard IIV. That gives better antibody levels and reduces hospitalization rates. There's a hint that it may reduce mortality if you extrapolate severity of illness, better antibody levels, and reduced hospitalizations. We're hoping that we get to a reduced mortality. Same kind of data available for the recombinant influenza vaccine, RIV4, and also the adjuvanted vaccine, which has an adjuvant that stimulates the immune response called MF59 adjuvant. That's used in some other vaccines as well, but it's in the adjuvanted flu vax. So ACIP does not recommend one over the other. They prefer that patients over 65 receive one of these vaccines instead of the standard IIV quadrivalent. If these vaccines are not available and the option is standard IIV quadrivalent, then we give that to our patients over age 65. It's better than not receiving anything, but these are the preferred vaccines now. Next slide. So let's shift gears and talk about Pneumovax Pneumovax and pneumococcal vaccines in general. We have some new recommendations in 2022 for pneumococcal vaccines, which is pretty exciting. As you might recall, we've been using PCV13, the pneumococcal conjugate vaccine, in our adult patients as a nuanced indication since about 2012, and as a blanket indication for everyone over 65 since 2014. And largely because the conjugated vaccines have made such a difference in the incidence of pneumococcal disease in children, the impact of pneumococcal disease worldwide and in the United States is rather dramatic. We tend to see perhaps 320,000 cases of pneumococcal pneumonia in the US each year, 150,000 hospitalizations for pneumonia and invasive pneumococcal disease, and about 5,000 deaths. So this particular organism / infection certainly has an impact in mortality and morbidity, and we would like to impact that with our vaccines. So now the PCV13 conjugated vaccine is being replaced by PCV15 and PCV20. As you might guess from the numbers, PCV15 has 15 glycoprotein antigens in it, and PCV20 has 5 additional. These vaccines were developed concurrently by different companies, and both were approved by the Food and Drug Administration at around about the same time. So I have pretty good data on their effectiveness, and the recommendations for the use of these two vaccines are similar but not identical. So current recommendations from ACIP in 2022 suggest that patients at age 65, if they haven't previously received a PCV vaccine like PCV13, that they receive either PCV15 or PCV20. If the patient gets PCV15, they should subsequently receive the old Pneumovax vaccine, the 23-valent polysaccharide vaccine, a year later. PCV13 is no longer available, but patients who have been immunized with PCV13 are still around, and they may be asking, well, what should I do if I've already had PCV13? Should I get PCV15 or PCV20? And the answer has generally been no. However, subsequently, ACIP in meetings this year have recommended that we do have the option of giving a booster at 5 years for a patient who has previously received a PCV vaccine. So a little more on that later. There are special indications for patients to receive PCV. If they're aged 19 to 64 and they have certain nuanced indications that are listed on the slide, such as immunosuppression, HIV infection, functional or anatomic asplenia, cochlear implant, CSF leak, chronic heart, lung, liver, or kidney disease, diabetes, smoking, and alcoholism. They're all indications for pneumococcal immunization prior to age 65. And again, we like to start with a pneumococcal conjugate vaccine for those patients, and then we like to supplement them a year later if they receive PCV15 with the pneumococcal polysaccharide vaccine 23. If the patient receives PCV20 at age 65 or at age 19 through 64 for special indications, they do not need to receive PPSV23 a year later, because we've got pretty good coverage of 20 pneumococcal antigens with PCV20. So there's the difference between using those two different conjugate vaccines. So if a patient has already had PPSV23 for some reason in the past, but they haven't yet had pneumococcal conjugate vaccine, and they have an indication for it, say at age 65, then you can give PCV20 at age 65, and then they don't need to receive any further pneumococcal vaccines. If the patient had a special indication for pneumococcal vaccine in the past, let's say they at age 55, they received PPSV23 for their asthma, and they've never had pneumococcal conjugate, then you can give PCV20 or PCV15, preferably 20, since it has better antigen coverage. So hopefully that's not confusing. I think it's a little simpler it's nice to have products that give us potential better protection against the additional antigens. And hopefully we can have widespread implementation of these. Next slide, please. So these curves will show us the impact of PCV7, which was brought forth for the pediatric population in the year 2000 or so. And with the inclusion of that in the pediatric immunization schedule, you can see a significant drop in the incidence of disease related to the pneumococcal strains that were included in the PCV7, the 7 different strains with regard to their unique antigens. And that, of course, has impacted the incidence of pneumococcal disease in the adult population. So as we see less pneumococcal infections in the pediatric population, it would follow that adult patients have less exposure to the pneumococcus through children, daycare centers, and families. And we've also seen a similar impact of the introduction of PCV13 for children, covering 6 additional antigens over the PCV7. And of course, adult population is receiving some protection against those additional strains as well. So as a result of that, for a short period of time before we've had the new pneumococcal conjugate vaccines come out, the ACIP schedule had, for the last couple of years, indicated that we just have a discussion with our patients about whether or not they ought to receive PCV13 and administer that based on the outcome of that informed decision making, and also based on a risk assessment of the adult patient. Are they at particularly increased risk for pneumococcal disease or just average risk? And if so, the patient could decide whether or not they wanted to receive PCV13. So now we have a somewhat blanket and easier recommendation that we give pneumococcal conjugate vaccine to everybody 65 and up and those who have special indications. And next slide, please. So what do we do with Pneumovax or PPSV23? Does that go away? No, we're still going to use it to boost folks who have had PCV15. And beyond that, we're not giving additional doses of PPSV23 as we did in the past. You can remember there was kind of a stepped hierarchy of mild, moderate, or severe risk for pneumococcal disease based on the patient's conditions. And now we're just making it easy, saying give PPSV23 to anyone who's had PCV13 or 15 before, and 1 shot, and that's it, no additional. So what about boosters for pneumococcal conjugate? So your patients had PCV20, and then they want to know about boosters. Now, for the first time, ACIP recommends that we consider giving a booster of pneumococcal conjugate vaccine 5 years after they have received their last pneumococcal vaccine. So if the patient had PCV15 in the past and then they got PPSV23 a year later, and now 5 years go by, you have the option of giving them a PCV20 vaccine to boost them once. This should particularly provide additional protection for our patients who are immunosuppressed. We can think of patients with CLL and multiple myeloma and HIV who might experience pneumococcal bacteremia and invasive pneumococcal disease, perhaps meningitis or septic arthritis. And hopefully we would have more of an impact on those conditions with a booster. Next slide, please. So these are the scenarios. Keep in mind the special indications for pneumococcal conjugate vaccine. And for patients over the age of 65, we'll think about a booster 5 years later. If a patient's had PCV13 in the past, they can receive PCV20 or PPSV23 at least a year after they had received PCV13. Next slide, please. To help us with understanding the recommendations for pneumococcal vaccines, the CDC has this app, which can be downloaded for free from the CDC website and also from the places where we get apps for our cell phones. And I would encourage you to download this and take a look at it. If you're seeing patients and administering vaccines, you can find that it would be very helpful in making the most sense out of the most recent recommendations. Next slide, please. Let's shift gears and talk about hepatitis B. The new recommendation from ACIP with regard to hepatitis B immunization is that all persons between age 19 and 59 receive hepatitis B vaccine series if they have not previously received it. That makes our recommendations for adult patients a heck of a lot easier than having to remember that big long list of indications for hepatitis B vaccine. So what's the problem with hepatitis B in the United States? It's something that we don't see very often compared to its sister hepatitis virus, which is hepatitis C. We see a lot of hepatitis C. The prevalence of hepatitis B in the US population is only 0.3%. Most of it is imported from other countries. The incidence is 3 to 5% in foreign-born persons, and that accounts for about 70% of the cases of Hep B in the United States. But we know that it's a significant public health problem. We do see it particularly in certain populations, patients who are immunosuppressed, patients who are dialysis patients, and also folks who are diabetic. Interestingly, this came from an Annals paper back in 2017. 2/3 of persons with hepatitis B don't know that they have it, and only 10 to 15% of those who do know that they have it are referred for treatment. That's pretty alarming since we have effective treatment for hepatitis B, and that clearly is something that we need to do a better job with. So that particular paper in the Annals of Internal Medicine stressed the importance of screening, vaccination, and linkage to care. And ACIP, I think, was motivated in part by some of this epidemiologic data and recommended that we start getting this vaccine into our population on a more regular basis and not just trying to remember that long list of nuanced indications. So we do have quite a number of hepatitis B products. We have 2 vaccines that we use in a 3 vaccine series. I'll show you that on the next page. And then we have a new vaccine, which was approved back in 2017. It's a recombinant hepatitis B surface antigen product with an adjuvant. This is a different adjuvant that's in the influenza vaccine. This is a 2-dose regimen, 6 months apart, and it's been shown in some of its pre-marketing data to have improved efficacy in diabetic patients compared to the previously available hepatitis vaccines. Next slide, please. So this stresses the simpler recommendation of giving hepatitis B vaccine series for all people between age 19 and 59 who have not previously had it. And then what about patients over the age of 60 who have special risk factors for hepatitis B, or if the patient just wants to get protection against hepatitis B, we can certainly administer it in those folks as well. That's a deal between the patient and their physician based on a risk assessment. Shared decision-making is recommended for people over the age of 65. Again, these are our patients who are hemodialysis patients or diabetics and other risk factors. Next slide, please. That are shown on this slide. So this is the old list of rather long list that we've had to keep in mind with regard to all those who are at risk for hepatitis B. A frequent question that comes up is, what do we do with people who have fatty liver disease? We know that the spectrum of fatty liver disease is broad, from people who are asymptomatic with mild ALT, AST abnormalities all the way up to folks who have cirrhosis. And the current recommendation with regard to fatty liver disease is that we perform an assessment of patients, and if we find that they have persistent abnormalities of their liver function, either by laboratory testing and or imaging, that we consider giving hepatitis B and hepatitis A vaccines to all those persons, regardless of severity. So if you assess your patient and you think that they have steatotic liver disease, then the answer is just give the vaccine. So down here on the second line from the bottom, you can see that we have 3 3-shot series available now: Recombavax, Engerix, and the new one, Hepislav. let me try and say that again, Heplisav-B, which is the 2-shot regimen. The other 2 or 3-shot regimens at 0, 1, and 6 months. You need to make sure that shot number 2 is given at least a month after shot number 1, and that shot number 3 is given at least 4 months after shot number 2, and at least 5 months after shot number 1. So there are right ways to do those. For our hemodialysis patients or immunosuppressed patients, there's a 4-dose regimen of Engerix-B that can be used, where doses are given at 0, 1, 2, and 6 months. The reason is that these 2 groups of folks are at increased risk for being non-responders to the 3-shot hepatitis B regimens, and therefore enhanced antigen exposure is recommended with the 4-shot regimen. Also, we might want to include health care providers in that group. We know that the incidence of non-responsiveness to hepatitis B vaccine in healthcare providers, about 15% don't respond to the vaccine and require a second series. It's not currently in the ACIP recommendations, but it might be in the future. And I think that is deserving of further consideration. Next slide, please. And just, here's some data with regard to the link of hepatitis B risk and the diagnosis of diabetes mellitus. Multivariate analysis have demonstrated that diabetics are at approximately 2 times the risk of developing acute hepatitis B as compared to non-diabetics. Some of this data comes from institutions such as nursing facilities or group homes. And, diabetics use sharp objects such as lancets and insulin syringes, and therefore blood and body fluid exposure risk is higher, and that might explain the additional hepatitis B risk, but there may be additional risks that are related to immune system function of diabetic persons. So we just need to consider diabetes mellitus as a condition that increases the risk of hepatitis B, and make sure that we're talking to all of our diabetic patients about that risk and about the additional immunization recommendation. Next slide, please. So here's some information on hepatitis A vaccine. We know that ACIP has re-upped their recommendations for additional risk groups that should receive hepatitis A vaccine, and that includes intravenous drug users, people who abuse other drugs, not necessarily by intravenous drug route, and also homeless persons. Over the past 5 years, epidemiologic data has indicated a dramatic increase in the incidence of hepatitis A in these populations, and we should be targeting them for receiving hepatitis A vaccine. We do have a lot of exposure to these folks in the inpatient wards, and when folks come in with alcohol withdrawal syndrome, or opioid withdrawal, or the treatment of opioid use disorder related infections, we have the opportunity to address the hepatitis A vaccine indication with these folks, and also with our patients who are homeless. So we are giving some vaccines in the inpatient setting, and frequently have discussions about both hepatitis A and hepatitis B vaccine in folks in these risk groups, as well as people who have liver disease. There are other patients who have indications for hepatitis A vaccine. It's not broad-based across the population, but men who have sex with men. We talked about chronic liver disease, people who receive coagulation factor concentrates because of conditions such as hemophilia. And it's okay to use hepatitis A vaccine if you have a high-risk pregnancy patient. People who work with hepatitis A infected primates, research lab settings, and an unvaccinated person who will be going to an area where hepatitis A is endemic, or if they're going to be having an adoptee from another country come into their home, they should be immunized against hepatitis A. And now ACIP has offered the option of immunizing people who are just concerned about their possible exposure to hepatitis A. If they don't fit any of the risk groups, we can still have a discussion with them about the vaccine and administer it if that is their desire. Next slide, please. Herpes zoster vaccine has gone through a major transformation over the last 5 years. The recombinant herpes zoster vaccine became available for use in October of 2017 and had significant advantages with regard to its effectiveness against preventing herpes zoster compared to the previous vaccine, which was a live attenuated virus vaccine, which was about 50% effective in preventing outbreaks of herpes zoster in folks who were over age 60. The new vaccine, RZV, a recombinant subunit vaccine, is about 90% effective in preventing herpes zoster outbreaks. It's indicated for people age 50 and up. It's 2 shots over 2 to 6 months. Usually it's given about 6 months apart. The vaccine can cause significant local adverse reactions where you get swelling in the arm and some redness of the skin. Not an infection, but just a local reaction, and really need to counsel our patients about this because many of them will experience it. Up to 79% will have some sort of local adverse reaction and some systemic side effects as well, like low-grade fever and malaise. So we need to counsel our patients and say, tell them what herpes zoster is all about, tell them the significant pain that people can experience acutely when they have herpes zoster, and then the risk for post-herpetic neuralgia down the road, which can be a chronic condition that requires ongoing medical attention. Our patients who are at highest risk for herpes zoster outbreaks are older folks, particularly 70s, 80s, 90s, as we experience immune system dysregulation as we age. Our risk for having herpes zoster outbreaks is increased. And the oldest folks are the ones who suffer the most with the acute pain from herpes zoster. Sometimes that pain in and of itself is a reason for admission to the hospital. And of course, it also depends on where you develop the herpes zoster outbreak. Cranial nerve herpes zoster can be disastrous. We see Ramsay-Hunt syndrome, which involves the 7th cranial nerve, ear, tongue, facial involvement, severe pain. And we can also see contiguous cranial nerves involved. I had one patient who developed cranial nerves 9, 8, and 7 involvement with their herpes zoster. That patient developed swallowing dysfunction and died from aspiration pneumonia as a complication of having developed herpes zoster. So it's a it's not just a painful nuisance, it's a disorder that can have significant impact on one's life. So now we have a vaccine that's perhaps 90% effective, even in older patients, and that looks like a durable immune response. It doesn't decline within 5 years of receiving the vaccine like the previous live attenuated virus vaccine that we had. So this vaccine can be stored at standard temperatures, just like our other vaccines in the refrigerator. The previous live attenuated vaccine needed to be stored in a freezer, and a lot of physician offices didn't have that type of freezer. So many patients were just getting referred to the pharmacy for the previous vaccine. This one can be stored along with the other vaccines. Post-marketing data for herpes zoster recombinant vaccine demonstrates that there is a slight increase in the risk of Guillain-Barré syndrome with this vaccine. We had that data become available to us in the spring of 2021, and it looks like the excess number of cases for Guillain-Barré syndrome associated with RZV is about 3 per million above the baseline incidence of Guillain-Barré syndrome in the general population. So it's not a huge risk, but GBS is scary and can be fatal. So our patients need to know about that ahead of time. This slide shows the data from the ZOE studies done in people 50 and up and 70 and up, which demonstrated the very durable immune response to RZV with regard to preventing the herpes zoster. Next slide, please. Wouldn't it be great if we had a vaccine that prevented cancer? Well, we do. Human papillomavirus vaccine has rather impressive cervix cancer prevention data associated with it. And the vaccine that's available now is HPV-9, which has 9 different strains of HPV that cause 65% of the cases of cervical cancer. Strains 6 and 11 cause 90% of the cases of anogenital warts, and those 2 strains are included in this vaccine. In 2014, 5 additional strains of HPV that are oncogenic were added to the current vaccines of the day, HPV2 and HPV4, to make HPV9 and give better protection against squamous cell carcinomas of not just the cervix, but the penis and the anus. And also we've seen HPV-associated cancers in the oropharyngeal region as well. So this vaccine looks like it has broad applicability to the prevention of cancer in young people. The current ages that are recommended are starting at age 9 to 14 for the first shot. And if we give the first shot to the 9 to 14-year-olds, then we can give 1 more dose at least 5 months after the first dose, and that completes the series. If we start the immunization series after age 14, then it becomes a 3-dose regimen, sort of similar to the hepatitis B schedule at months 0, 1, and 6. We'd like to expand the availability of this vaccine to patients that are older than age 26. So for the age group between 27 and 45, it's a shared decision-making thing based on risk. So discussion of physician with patient about their risk factors. Anybody who has more than 1 sexual partner in 6 months is considered at increased risk for exposure to HPV. So we need to keep that in mind as we talk to our patients who aren't monogamous. If the patient is pregnant, we prefer not to give this vaccine to pregnant patients because we don't have good safety data on that. But anyone else tends to be a pretty well-tolerated vaccine. With this group of vaccines, the HPV vaccines have been associated with a slightly increased risk of syncope after the initial shot. So we'll hang on to people for 15 minutes or so after we give them the dose and make sure that they don't get into trouble from that. Next slide, please. Meningococcal vaccines have become a little bit more complicated since we had the introduction of meningococcal B vaccine about 5-6 years ago. Meningococcal ACWY vaccine has been around for a long time. The so-called meningitis shot was classically indicated for preventing meningococcal meningitis in kids who are going away for their first year of college, if they were going to live in a dormitory specifically, or military recruits who are going to live in barracks, are recommended to receive 1 vaccine dose before they go away. And that's particularly if they haven't received a first dose during their early childhood. The standard dose for immunization of the adult population is 2 doses 8 weeks apart, and then it can be boosted every 5 years if the patient has risk factors such as anatomic or functional asplenia, HIV infection, terminal complement deficiencies that are persistent, and then there's the 1-dose recommendation for college students, first year, and military recruits. Other folks who are candidates for receiving meningococcal vaccines, microbiologists with exposure to that Neisseria bacteria, patients who are receiving biologics such as eculizumab or ravulizumab, which target terminal complement. Eculizumab has been used to treat paroxysmal nocturnal hemoglobinuria, which is a relatively rare myeloproliferative disorder, and I believe ravulizumab shares that indication. But our rheumatologists occasionally use these two drugs for patients with other unique inflammatory disorders. So they need to receive the vaccine before they receive the treatment with those. So what do we do with meningococcal B? It does not have a blanket indication for the general population. The nuanced indication of these meningococcal B vaccines, of which we have two unique ones, are higher risk patients like microbiologists with exposure to the organism. Again, the shared risk factors that we just mentioned for folks with meningococcal vaccine, ACWY, and some colleges will now require meningococcal B vaccine before a student is allowed to attend the college based on their previous experiences with outbreaks. So during an outbreak in a local area based on epidemiologic data that's available to us from our local public health organizations, meningococcal B vaccine can be put into use based on the outbreak information. We recall Princeton University had an outbreak of meningococcal B back around 2015. And I believe there are several colleges that now require meningococcal B, but certainly not all. So it's something for us to pay attention to. A lot of times the student that we're seeing for a pre-college physical may come in and say, hey, they want me to have this meningococcal B vaccine. What's that all about? So what about the two vaccines? The meningococcal B Bexsero vaccine is a 2-shot series given at least 1 month apart. It has 3 recombinant proteins and outer membrane vesicle antigens in it. And it's not interchangeable with its competitor, which is called Trumenba. These names are getting more difficult to pronounce. And Trumenba also is a 2-shot series for average risk patients. It's a 3-shot series for people with increased risk based on immunodeficiency or if they're receiving those biologics, or the microbiologist should get 3 shots of the Trumenba if they decide to receive that one. The antigens in Trumenba are 2 purified recombinant lipidated factor H binding protein antigens. I did not memorize that. I put it on the slide. So what about interchangeability? You can't, if you start someone's Men-B series with Bexsero, then finish it with Bexsero, and likewise with Trumenba. Next slide, please. So measles is still around, unfortunately. As I mentioned before, most measles has been imported over the last 30 years. The last outbreak that we had in this area of the country was back in 1991. I remember there was an outbreak down in Union Hospital area in Cecil County, Maryland, which is when I saw my one and only measles case. But we hear about micro outbreaks from time to time. I put Mickey Mouse on the slide because there was an outbreak from exposures in Disneyland out in California a few years ago. There were 130 cases associated with that outbreak, and only a third of the people who acquired measles through Disneyland exposures had previous vaccination. I think there's the anti-vax movement out in California is more dramatic and more unvaccinated people out there. So we had renewed interest in making sure that everyone received their MMR vaccine, and our schools and colleges do a good job of making sure that everybody's had 2 doses of MMR before they are allowed to attend the schools. So what about adults? So we get together and ask our adults their immunization history, and many times adults have no idea what vaccines they've received before and don't have a copy of their immunization record. So we'll ask them, have you received any measles vaccine in the past? And if not, we can measure an antibody test. If the antibody test is negative and they don't recall having had the vaccine before, then they should just receive a dose of MMR vaccine. People who were born on or after 1957 are at increased risk for measles. Those who were born before 1957 have likely had measles, although that's not universal. And if we're not sure, we can always measure measles antibody. Healthcare workers are all screened at the time of their employment for measles antibody, regardless of their history of having had the disease. And if the titer is negative, they'll be recommended to receive 1 dose of MMR. So what about the 2-dose regimen? Certainly our children are receiving MMR after the first year of life and then prior to attending school. So they've got 2 doses on board. If students who are attending college have not had evidence of a second MMR dose, then they're given one prior to going. International travelers may be at increased risk based on where they're going. If you are a household member of someone who has an immunocompromised person in the house or HIV infection, if you have HIV infection with a CD4 count of greater than 200, you can receive MMR vaccine. Patients with a CD4 count of less than 200 probably should not receive that because it's a live virus vaccine and they'd be at increased risk for developing disease. What about mumps? Because the mumps antigen is included in the MMR vaccine, and we have seen some mumps outbreaks locally. There was one at the Chase Center associated with a social activity a few years ago. And the mumps immunity may wane over time after folks have had mumps immunization from MMR. There's ACIP has put forth a recommendation that we consider giving a 3rd dose of a mumps containing vaccine if there is a local outbreak reported by epidemiologic review. So if we have a local outbreak, anyone who is at increased risk for mumps based on having had a vaccine a long time ago or having serologic evidence of no antibodies, then a booster dose can be given at that time. Next slide, please. So these are 3 vaccines that I decided not to cover in any detail today, just based on time. But I would like to make a comment about Tdap, because there have been some minor changes in Tdap over the last few years from ACIP. Tdap is tetanus, diphtheria, and acellular pertussis vaccine. The uptake of Tdap by the adult population has not been very high. The National Health Information interview conducted by CDC has determined that uptake of tetanus vaccine reported by individuals is less than 50%, any tetanus vaccine, not just Tdap. So, and of course we have acellular pertussis included in that, which prevents whooping cough. And we have some populations that are clearly under immunized for pertussis, including the Amish population over the border in Pennsylvania and also down in Kent County, Delaware. So we do have some folks who are relatively under immunized for this. Current recommendations, if our patient has not had a primary series of Tdap, we recommend starting with Tdap as the first vaccine, and then the 2nd and 3rd doses can be TD or Tdap. It's a 3-shot series given over 6 months as a primary series if your patient has no recall of having had tetanus vaccinations in the past. So we can start with Tdap and finish it. What about wound prophylaxis? If someone has a wound that may be tetanus prone, it's contaminated with dirt or it's deep, that patient should receive Tdap as their post-exposure prophylaxis vaccine immediately after attending to the wound, especially if they haven't had Tdap within the last 10 years, or if they haven't had tetanus booster of any kind in the last 5 years if it's a tetanus-prone wound. For just minor lacerations or superficial scrapes, if somebody hasn't had a tetanus vaccine in the last 10 years, they should receive Tdap. And then finally, for our pregnant patients, ACIP is recommending that we give a Tdap with every pregnancy. So your patient has 3 pregnancies over 5 years. She's going to be recommended to receive a Tdap booster with each of those 3 pregnancies, even though they've had a TD or Tdap booster within 5 years of those pregnancies, to increase the mother's immune response to pertussis so that she's less likely to acquire pertussis and give that to her child. So we try to create the cocooning effect of immunizing the family. And not only do we administer the vaccine to a pregnant mother in the 3rd trimester of her pregnancy, but we also assess the other members of the family that are going to have regular contact with the baby and make sure that they are up to date on their Tdap vaccination as well. So otherwise, the varicella recommendations and the Haemophilus influenza B recommendations haven't changed substantially over the last 5 years, and they're available on the CDC website. Next slide, please. This is an immensely useful app from the CDC, which includes all of the immunization schedules that we just reviewed for not only adults, but also for children, and it's updated on an annual basis. I would recommend anyone who's interested in vaccines or is seeing patients and responsible for administering vaccines, download this into your cell phone and you've got something to refer to. I carry this with me. I tell the residents about it and have them do it. And it's a very useful resource for reminders, because as we've seen, there's a plethora of information about all these immunizations, and it's hard to remember everything 100%. So it's nice to have clarity when you're recommending a vaccine that perhaps you don't recommend every day. So please take advantage of that tool. Next slide, please. If you're doing practice-based or office-based immunization, you need to have this handout. It's a 100-pager that's from the CDC website, and it's updated just about annually now. That's just about everything you need to know with regard to vaccine storage and handling. It's a toolkit. I know everybody winces when they hear the word toolkit, but you shouldn't be giving immunizations without looking at this and keeping it available as a reference for yourself. It talks about storage, talks about temperature. It talks about the size of the needle that you should use if you're administering vaccines to patients based on how big they are, how much muscle they have on their body. It's an extremely valuable resource. And again, it's updated on a regular basis. So a great tool to have available. Next slide, please. So in summary, we've gone over some of the most recent changes recommended by the ACIP for the adult immunization schedule. This is published annually on the CDC's website, also in the Annals of Internal Medicine, and some other medical journals as well, and societies that endorse the annual ACIP schedule. I recommend that you download the CDC immunization app on your cell phone so you can remember all of this data in detail. And keep in mind the immunize.org website for information about immunization, especially vaccine information sheets are available there. So if your folder is empty at the office and you need to download one, you can just pull it up on immunize.org and print it. Standing orders are available on there for adoption into practices. Standing orders, the use of standing orders in medical practices has significantly increased the uptake of vaccines by patients. And so they're a desirable thing to have available. The doctor doesn't have to order individually every vaccine for every patient. If you have standard immunization standing orders in your practice, that empowers your staff to identify patients who are in need of vaccinations and to administer those the day that they happen to be in the office, no matter what reason they're there for. So also check out the website of the Immunization Coalition of Delaware. It's action-packed and information-packed website that Dr. Smith maintains on a regular basis, and it's a great Delaware resource. There's links on there to Delaware public health sites where we can track the current progress of our current influenza outbreak, and also other things that we've heard about today, like RSV and COVID and monkeypox. So a great source of information that Dr. Smith maintains through the coalition. So I'd like to thank everybody for the opportunity to talk to you about vaccines today. And I'd be happy to take on any questions.
Thank you, Dr. O'Neill. There are two questions in the Q&A. The first one is about flu. Do you think that influenza B Yamagata influenza strain has gone extinct? And if so, is there benefit to the quadrivalent vaccines still?
I'm not aware that the Yamagata is extinct, and Mother Nature does what she wants to do, and if it's less common now, I certainly think that it's possible that we may see it return. So that requires ongoing surveillance on an annual basis. Whether it'll influence the decisions about which viruses are included in next year's influenza vaccine remains to be seen. So we do tend to see outbreaks of influenza B kind of later in the winter and early spring, and also in children. We tend to see a higher incidence of influenza B. So I think that the quadrivalent vaccine is here to stay. And it's nice to have protection against influenza B. It's sometimes the disease caused by influenza B is not as severe, but nevertheless, influenza is an unpleasant illness. We certainly see patients admitted to the hospital with influenza B on the internal medicine service, and would be interested in trying to prevent as much of that as possible.
Thank you. The next question doesn't specify, but I believe timing-wise it was about hepatitis B. Should foreign-born patients be screened for infection before they are vaccinated?
Certainly, we'll screen them with a history. Because of the higher incidence of hepatitis B in foreign-born persons, I think it was 3 to 5% that I had quoted. I think it's reasonable for us to look at their antibodies if we have any question about that. A lot of the hepatitis B incidence from other countries is vertical transmission from mother to child. And in that setting, that's where we see most of our chronic hepatitis B. The child's immune system is underdeveloped, and the hepatitis B virus sets up shop and continues to cause chronic active hepatitis during childhood. And then those patients can develop cirrhosis in the meantime, and they also have a higher incidence of hepatitis B surface antigen positivity and are therefore infectious toward other people. So I'm in favor of looking at the hepatitis antibodies of people who have come from other countries, particularly if they're not sure about their medical history and if it hasn't been done previously, because as we pointed out, 50% of people who have hepatitis don't know that they have it, hepatitis B. And so we can help them out by looking at specific antibody studies. The one to do would be hepatitis B core antibody total. And a lot of folks don't know about that particular test. In addition to the surface antigen test, which should be checked, would also check the hepatitis B core total antibody, which includes both IgG and IgM. There is no individual hepatitis B core antibody IgG test available. That's available for hepatitis A, but not for hepatitis B. So we need to keep in mind the total antibody test. That's the one to look at to see if the patient has had hepatitis B before. The antibody test that we use for folks who have had immunization to hepatitis B is the surface antibody. So when we're assessing for disease, we usually don't measure the surface antibody. We only use that for folks who have had immunization. We use the core antibody total, IgG plus IgM, to assess for disease. And we always include the surface antigen, which correlates with infectivity.
Thank you. Next question, should patients who receive this 2 or 4-valent HPV vaccine get revaccinated now with the 9-valent vaccine?
That's a great question. So currently the recommendation is no, but my understanding of that is that that may change in the future to offer additional protection against those other 7 or 5 antigens that are potentially oncogenic, but there's no official recommendation that the vaccine be updated for people who have had the 2 or the 4. Remember, the 2 vaccine, HPV2, included the 2 strains, and I think it was 16 and 18, that were most likely correlated with the incidence of cervix cancer. So you still get pretty good protection from that. If it were me, I would want the HPV9, obviously. I think we'll probably see more on this, particularly as we develop vaccines that have even more HPV strains in them, similar to what we do with the pneumococcal conjugate vaccines. We're interested in giving as much protection as possible, especially against oncogenic strains.
Last question. If you have had hepatitis A, should you still get the Hep A vaccine?
We don't recommend that. Hepatitis A usually provides, the disease hepatitis A usually provides robust immunity. The exception to that would be someone who has immune system impairment. And that's a gray zone or between the lines recommendation right now. So if you've had hepatitis A before, if you measure the antibody, it's usually easily detectable, the IgG hepatitis A antibody. And there's no recommendation for additional protection against that.